Well, good evening, everybody. Tonight we're going to do a webinar on Introduction to Manual-osteoperforation and High-Frequency Vibration. And so for the next hour, we're going to talk about how to put that into your practice and what that might look like. And tonight, introduce myself. My name's Eddy Sauer, and I live in Amarillo, Texas, and practice in Amarillo, Texas. We'll go through these other things. First off, I need to let everybody know that I'm not employed by a dental company. I don't own any stock, securities, or interest in any dental company. None of my family members own any stocks or security or interest in any dental company. But I have consulted or evaluated products for the following: for Propel Orthodontics, for Align Technology, for CEREC specifically, and for Patterson Dental. I have been compensated in the past. I've been compensated in the past for evaluating products for the sponsors of including Propel, and for my part in this event, I've received an honorarium from Propel. The opinions expressed in this presentation are my views and may not necessarily reflect the views or policies of the sponsor. The materials provided are for educational use and are not to be used for advertising or product endorsement purposes, and this presentation has not been approved for continuing education credits. No photographs, video, audio recordings permitted during this. Okay, enough with all of that. So my name's Eddy Sauer, and this is what it looks like out my window. This is Amarillo, Texas, and if you don't know where Amarillo, Texas is, right there in the top of the Panhandle. That's where I live and practice. A little bit about me. Here's my family. I'm the king. I've got 4 girls and 2 granddaughters and 1 son-in-law. So I'm completely surrounded by women, and thank goodness my girls think I hung the moon. So whenever we get into the science behind manual-osteoperforation, we're going to look at, really, I want to make for sure that we just go back to the very beginning and kind of get the real basics before we talk about how it affects with our patients. So just a good typical deal here is with bone injury, there's always going to be an inflammatory healing response. And whenever that injury occurs, you're always going to have the cytokine production is going to increase. And whenever that increases, you'll also see the rate of bone remodeling. It will increase, and the density of the bone will decrease because of the inflammatory response. So whenever we look at it in the forms of like orthodontic movement, then what we'll end up seeing is whenever you put a force on a tooth, there's going to be a pressure side and there'll be a tension side. And so in that pressure side, you'll see vascular constriction, which is just, really pretty typical. You're going to see the blood vessels will be, you'll see that the blood vessels will be crushed in that area, the fibers will be displaced, and on the tension side, you're going to see the cells proliferate and fiber production. Those are the normal things that are just pretty natural that you'll see. Also, when you look at it on the tension side, you will see that these right here that I'm pointing to, they're the osteoclasts, that they will move out of the bloodstream. The macrophages move out of the bloodstream, and they'll cause them to start to destroy the bone. While on the other side, on the tension side, you'll see them pull, and you'll see actually the osteoblasts begin to form and to bring that forward. So this is how that all looks as the blood vessels and the monocytes fall out, and they become the macrophages, and then they'll move into either, depending upon which side you are, either you'll have the osteocytes or the osteoclasts, and that way you will see either bone building on the tension side, and you'll see bone destruction occurring on the pressure side. So you get resorption, reversion, then formation, and then mineralization. One of the basic studies that gets used a lot is the New York Clinical Study, and that's where they used Propel. and that study had 20 patients in there. They used a handheld appliance, and basically the big thing to learn out of that study was the fact that what they found out was whenever you started to increase the bone inflammatory response in the moving the teeth, and you use the Manual-osteoperforation, what you would end up seeing is a 2-time increase in the velocity of the movement that actually occurred, which actually ends up meaning then that you can move the tooth twice as fast, and therefore if you're doing clear aligner therapy, you should be able to change your aligners twice as quickly. The interesting thing that also comes out is that the patients only reported mild discomfort and only at the spot of where the MOPS actually occurred. So out of this study was done with brackets and wires, and you can see from the top here, there's the ortho on one side only and the Manual-osteoperforation over here on the left side, on the right side, and as it moves down, whenever you get to the bottom, you can see that the tooth actually moved, the cuspid actually was pulled significantly farther than it was on the right side. So there's different ways that you can accelerate the orthodontics that are out there today. And one of those ways is by using a low frequency vibration. And it's indicated to help make minor tooth movements. The problem with it is that you typically are supposed to take the aligners out during the treatment. And it requires that you also have to wear the device for 20 minutes a day. So you've got a pretty significant amount of patient compliance that's going to be required for you to be able to, for this to be successful. And on top of that, the price either to you or to the patient is pretty significant. It's about, or was about $1,000 the device. Whereas there's also the high frequency vibration, which is the V Pro 5 that's made by Propel, and its main indication is it's going to assure that you get a good aligner seating. The other good thing about it is, you know, you're only going to have to, it's only required for it to be effective is by wearing it 5 minutes a day. The cost is less than half of what it would be if you were using the other, and it also relies on patient compliance. But, you know, patient compliance is going to be a whole lot easier if you're only having to wear it for 5 minutes a day and you can keep your aligners in at the same time. So that's really a pretty important thing when it comes to having your patients being compliant with the things that you're wanting for them to do. Now, the ultimate patient compliance would be if we do accelerated orthodontics by doing increasing the inflammatory response. There are 3 different methods that are out there. One of them has been around since the 50s, the corticotomy, which has also been called Wilcodontics, and it's pretty invasive. You're going to reflect the flap. They're going to take out the cortical bone in between teeth. They're going to lay the flap back down. Typically, that's going to be done by a surgeon most of the time, and it's going to be quite expensive, and it's probably going to have some pretty good recovery time. Then also, the next thing that came along was they refined it using a piezo, but basically pretty much doing the same kind of deal. Then along came the Manual-osteoperforation, which was basically a micro-invasive, very little patient recovery. There's a low cost to the patient, and the training is really pretty simple. So we're going to look at the Manual-osteoperforation. So right now, there are 3 ways that the delivery system actually works. And the 3 different ways that the system works is you can do a single use, where basically you just use it once and then you throw the whole thing away. They come either with a depth limiter on there so that you know that you're going to an exact depth, or you can do it without the depth limiter on there. Then the next version that came along was that has a reusable handle, and all you had to do was place the tip on it, and then you would be able to get the same thing. One of the nicest things that actually came along is actually the power device, which you can see on the far right side. And that power device, it limits the RPM to 45 RPM, and basically it's going to have a reverse functionality. Whenever you hit enough resistance for depth, then it will reverse back. It's fully rechargeable, and it actually works really well and is very easy to use with the patients. So whenever we start talking about the benefits of doing the manual osteoperforation. The first thing that we're going to talk about would be patient benefits. The first thing for the patient is it's minimally invasive. You can perform it chairside in minutes. Typically, whenever we're doing it in our office, once our patients are numb, and we typically can do that with just using a topical that we order from a pharmacy, and we place that on, and once that topical has been placed and we know that they're numb, then I can walk in the room and actually probably in less than 5 minutes, I've actually already completed the treatment on upper and lower. You can use it whether you're using clear aligner therapy or whether you're using brackets and wires. There's really no patient recovery time needed. They can get up, go back to work. Most of my patients turn around and go right back to work, and it's typically not a problem at all. The doctor is going to control it. You don't have to worry about any kind of compliance later on. You're just setting up that inflammatory response, and the body takes over and works from there. It saves time. Less office visits means less time that you're going to be away from work. Also for your practice, we'll talk about the practice benefits as we walk through this next part of it, because I've got several cases that we'll walk through on the practice benefit side of it. And whenever we're talking about the practice benefits of it, I'm going to be pretty transparent. You're going to see some of the things that I ran into that have kind of helped develop the way that we handle it in our practice today. Usually there's going to be an increase in your patients accepting the treatment, and it's going to keep your patients. And I've got a really good case that I'll show you where we had a patient that was burning out on us, and if we hadn't have had that, I don't know if we would have ever completed the case. So this is the way that we do the way that we set it up whenever we're going to go in and we're actually going to do the Propel. The first thing that we're going to do is we're going to evaluate the treatment area. We're going to palpate that tissue, make for sure that we don't have things that would make this be less effective and not work, like toroid that sometimes you might see facially or lingually. We're going to palpate that tissue. We're also going to evaluate the x-rays. We want to make for sure that we've got plenty of space in between the roots so that we are not going to run into the possibility of hitting the root while we're trying to do this. And typically that's never been a problem, but it's always good to have a set of x-rays to make sure that we don't have any nerves or vascular system that could be in the way. The next thing that we do is we have our patients rinse with chlorhexidine rinse. They're going to rinse 2 times for 1 minute each time, just to make for sure that we've got a really nice, relatively sterile environment. Then the next thing that we'll do is we'll anesthetize, and then we'll do our acceleration. There are very few times, if you're very careful with this local anesthetic, what we'll do whenever we're using the local anesthetic is we will use a isolite, or we'll use some other form of device that will help us pull the lips back out of the way, and then we'll dry the tissue and make for sure that the tissue is real dry. Then we'll paint on the local topical, and we'll let that topical set for about 4 minutes. Then we'll go back and we'll wipe that off to make for sure that we're going to keep sloughing to be at a minimum, because that does happen sometimes with some of these topical anesthetics. So we'll wipe that off, we'll let that set for a couple more minutes, and then my assistant will then take an Explorer and make for sure that everything is numb to that touch. And if it's not numb to that touch, then she'll go back and she'll reapply in a couple of those areas. And so all of that will be done by the time that I walk in the room. So whenever they feel like that the patient has been anesthetized enough by using the topical, I'll come walk in the room, and then I'll sit down and I'll do the same thing. I will touch and make for sure that we don't have any areas that there's a chance that they're going to feel anything at all. And then once that goes, once we for sure have them completely numb, then I will pick up the perforation device, and then we'll go from there and make our perforations. So in my experience, Most patients require 1 to 2 treatments. And from the ones you're going to see tonight, actually most of my patients, we usually do pretty good with 1 treatment. Complex cases may require 2 or 3 treatments, and usually you'll do 2 to 3 manual osteoperforations are recommended. The osteoclastic response, you need to remember, is going to be 6 to 10 millimeters around that treatment area. So if you consider, let's go at the 6 millimeter end of that, that means that you're in the premolar and the anterior area. You're basically wherever you make your perforation, that will create an inflammatory response that will extend all the way across the entire tooth. So for whenever we're doing that, we're going to make for sure that we're going to look at our tooth movement assessment, and we're going to make for sure that we are handling any moderate to complex movements, that we're making for sure that we have at least 1, if not 2 or 3 perforations around those. And then the next thing is we're going to select exactly how deep we want our perforation to be. Typically in the anterior and most of the time actually in the premolars, we're going to limit it to about 3 millimeters. Typically it doesn't take very much more than maybe 1 millimeter or maybe 2 millimeters to get through the tissue, and then another 2 millimeters just into the cortical plate. In the posterior area, sometimes if you're doing that, maybe 5 millimeters. Seldom have I ever done 7 millimeters. And honestly, I have not ever used the palatal depth to do any of the perforations on the depth side, on the palatal side. What you should expect is that you should have osteoclastic effects that are going to begin to peak in 24 hours, and they'll remain elevated for at least 10 to 12 weeks. So what that may mean is whenever you get 10 to 12 weeks in, you may feel like if you've still got some significant movement that needs to be made, then it may require that you want to repeat your microosseous perforations. So where do I perforate? Well, whenever I am going to perforate, I want to make for sure that it's going to be performed either buccally, and typically it's almost always buccally, and very seldom will I ever do the lingual access. We usually get more than enough of a response by going buccally. So the buccal access is most often the simplest approach, and it's going to be the easiest to get around in the patient's anatomy. So as far as the depth goes, here's a really good chart that you can use. So if you'll look and you'll see here, all of these that are in the anterior area, there's about a 3 millimeter depth. In the premolar area, about a 5 millimeter depth, and in the molar area, about a 5 millimeter depth. I will tell you, most of the time, typically we are getting deep enough in most people on the premolar area. Even just a 3 millimeter will be more than adequate, and we get really good movement and results out of that area. So whenever my perforation patterns are going to be this, whenever I've got an area that's going to have a difficult movement, a moderate or a difficult movement, that's where I might consider doing a 2 or 3 per site perforation. Typically what my other goal is going to be is I want to get about 8 to 10 perforations per arch, whether it's in the maxillary arch or the mandibular arch. Whenever I first started out doing this, we were really kind of centering on doing our perforations around the movements that we knew were going to be difficult. But what I seemed to find out is that if I spread my perforations out and I went from like first premolar or second premolar to second premolar all the way across, and I got anywhere from 8 to 12 perforations, that because of the extension of 6 to 10 millimeters of inflammatory response across the site, that I would get more than adequate amount of by doing single perforations, and then I would get excellent movement. And we'll talk about that when we start looking at some of these cases later on. So whenever we're doing the manual osteoperforation, this is really a pretty good slide to kind of show you what actually ends up happening. So whenever we look at this one over here, this one is a single use, and it has a gauge on it, so you are going in until you hit that gauge, and this is kind of what they're going to look like. You can see these different places where they're perforated. Here's a couple of my patients. So this is the kind of bleeding that you'll usually see that will be associated with it. On this case, we perforated all the way across from the mesial of the second premolar to the mesial of the second premolar. And whenever we got through, here's a result of how they looked right before we let the patient go. So here's the technique. For the SingleUse device, you can set that depth if you've got to and use the depth gauge on it, and you can set it at 3, 5, or 7 millimeters. I will tell you, when I first started, that's what I used because it made me feel like I had a little bit more control of what was going on, and I could have a better judge of what was actually happening. But I'll tell you, we got about 3 or 4 of these in, and once we had done about 3 or 4 patients using this technique, you know what, I actually didn't need the depth gauge really anymore, because what you begin to realize is you get a feel for, you can tell when you engage the cortical plate. And once you've engaged the cortical plate, just one little twist, and then you back it back out, and you basically have all that you need to be successful. Then we went to using the reusable handle, and it made it real easy to be able to get those done in place. The really nice thing was whenever the power driver came along. And the power driver made it even easier on the patient. So instead of having to make that constant screwdriver, for lack of better terms, movement on them, now then what ended up happening was a nice, slow, gentle turn of 45 RPM of the device. And all you had to do is just keep a constant pressure until you felt that tug. And once you felt that tug, then you could get it to back off, and it would back out. And so it worked really well. Right there, it's going to show you that the selected torque is about 15 Newton per centimeter, and that actually is going to be really pretty good, so that right about the time that it's going to grab that cortical plate, it'll twist in, and it'll stop and reverse and back its way back out. Now, here's probably one of the most important things that we need to remember, is that there is some tenderness around that, but I will also tell you that that doesn't last. It really doesn't even last for 24 to 48 hours. Typically, if you do that, by the time they have their next meal, they're typically really pretty much everything's under control. The one thing that you want to make for sure is you need to have your patients not taking NSAIDs, because pretty much basically what aspirin and what ibuprofen are intended to do is they block the inflammatory process. And by blocking the inflammatory process, now then you're really not going to have nearly the success that you're looking for. So let's talk about the high-frequency vibration, and then we'll start to show the cases. So the high-frequency vibration device, it's mainly going to be used to help seat the clear plastic aligners with 5-minute daily wear time. The good thing about whenever you're seating these appliances is if you're seating the appliance, you know that the right kind of pressure has been placed on the tooth to move it into the place where the aligner is intended to move the tooth for that period of time. So that's really how the high-frequency device works. You have the mouthpiece, you have the oscillation part of it. There it comes with a USB flash drive with preloaded summary software if you're going to keep up with if your patients are doing it, and it also comes with a wall charger and a charging cable. So the delivery, it's really pretty simple and straightforward. You just remove it from the package, you clean the mouthpiece, you make for sure that it's fully charged before the patient uses it, and then basically you go in and you can assign it to a patient, and then you connect everything, you press with firm pressure, and the switch will turn on and it'll activate the device, and the device will run for 5 minutes, and then it will stop automatically. So this is all the stuff about it. If it's blue, then the 5-minute cycle is in progress. You'll get 3 green blinks when it's completed. You'll get a continuous green light if it's fully charged, and those are the way to kind of give you an idea of exactly what the warning signs are with it. And so here's basically the software that goes with it. This will pop up, and this is where you'll go to be able to assign it to a patient and then get it activated for that particular patient. So the rest of the time we're going to spend today for the next probably about 30 minutes is we're going to look at some clinical cases, and we're going to see exactly how this is fleshed out in my practice. So the first case that we're going to look at is John. And interestingly enough, John is 71 years old. And we had a lot of dental work that John needed to have done. But whenever we started talking to him about it, we talked about the fact that, you know, he was really pretty healthy, extremely healthy, and a pharmacist. He's considered retirement, and he wanted everything to be in good shape. And so the easiest way to make most of his restorative work that he needed to have done would be if we put his teeth in the right position. And therefore, then we talked about using clear aligner therapy. So whenever we did that, John said, well, you know what, I'm 71, and I really don't want to spend any more time than I have to. And so we talked about using micro-osseous perforation on it, using Propel. And so whenever his case came back, we had 30 aligners that were going to take us from beginning to end. And so whenever you do that, and you consider that it's a 2-week change out, now then you've got a 15-month case looking ahead of you. So if we can cut his treatment time in half, which we could, now then we're talking about 7.5 months. Now then with John, the enjoyable thing about some of these old patients that are reaching retirement age is they're very, very compliant patients. And that's one of the things that I have found out through doing this is if you have very compliant patients, you really begin to see what clear aligner therapy and micro-osseous perforation will actually get you for your patient. So this patient, we actually only did one micro-osseous perforation at the very beginning. And he wore his aligners faithfully, and he changed them out. We quickly decided we were going to change them out every 7 days, and look at what the result was. I will tell you that in my practice, he is my poster child for clear aligner therapy and micro-osseous perforation. He moved perfectly all the way through. Our result was, as you can well tell, it was an excellent result. And he's ready for the restorative side of what we need to do where things have been breaking down on his old amalgams and placing an implant in that area on number 12. And so he's the epitome of what it can actually do for your practice. So the next patient is Kelly. So Kelly is a 54-year-old female. She was class 2, and she had some excessive overjet. Whenever you look at her arch form, which is one of the main things that we also look at, she had an omega-shaped arch form, which pretty much on her maxilla, if we look here, and if we look at the posterior and we're looking from the side, we can see that pretty much that she has a posterior collapse. And so by uprighting and creating some space and pulling these anterior teeth back in, we were going to be able to close her diastema. And she wanted to kind of get this thing going quickly. And then on top of that, she had several movements that were going to be a little bit more difficult. So her case, whenever it came back, she had 23 aligners, you know, just basically short of a year. So she had micro-osseous perforation done when we started Propel, and her treatment time actually ended up only being 5.5 months. This was completed in 23 aligners, and there was no refinement at all required for it. So pretty much she was completely happy with what her results were, which were actually stunning. If you look at that, you would think there's going to have to be some restorative work to make those anterior teeth turn out fine. And the end result was, look at how beautiful her smile turned out to be. Okay, so this is Ginger, and Ginger is 62. And whenever Ginger came in to get her normal routine prophylaxis and cleaning and x-rays done, we were talking about the fact of some recession that she was having and the beginning of some abfractions. And whenever we looked at her, she was pretty much had a class 1, had a little bit excess overjet, and she had an omega-shaped arch. And she was a pretty impatient lady in the fact of that she just really wanted to get things done, and the faster that she can get them done, that was going to be better for her. She just didn't know whether she wanted to. At that point in time, we had an additional fee for micro-osseous for the Propel. We would have one fee for our Invisalign, and then we would have another fee if we were going to speed it up or use, and I'll talk about how that ended up affecting our practice. So her case was 22 aligners. That was going to be 11 months on normal treatment. Her treatment actually ended up being 4 months treatment, and we did the micro-osseous perforation. After she got in and was wearing them and we were changing them out 2 weeks at a time, when it was time to deliver liner 4, she goes, I want this done faster. And so we changed her, we did the Propel, and then we watched her very closely, and we ended up doing a 5-day change out on her case. She went through 22 aligners on a 5-day change out. 4 months later, she was complete, and there was no refinement required at all, no additional aligners that were required in her case at all. And our result was pretty spectacular. So here's what I'll also tell you, that it's one of the things that we do. You can already tell I've had a 62-year-old patient, a 54-year-old patient, a 71-year-old patient already. All 3 of those patients are a little bit more mature, you might say, and chances are their bone may be a little less prone to want to move quite as well. So whenever we're talking to our patients, we talk to them about that inflammatory process. The way we talk to them about it is, if we wake that bone up, it is going to be more responsive to us getting the teeth to move. And so that's what how we explain Propel to our patients, is we use the terms that we're going to wake their bone up, and we'll make for sure that we're going to keep them extremely comfortable during the procedure. They won't have to worry about that at all, and their post-op discomfort will be minimal, if any at all. So this is Gene. So Gene is 70 years old. So if you look at Gene, Gene had a class 1 molar relationship. He's got a V-shaped arch. And if you look at the lower, you can really see from the lower occlusal view the fact that we've got a V-shaped arch. One of the things that were happening with the posterior collapse on him was he had a very destructive occlusion. His occlusion was so destructive that we lost tooth number 14 and we lost tooth number 19, and both of them had to have implants placed. So they already had implants placed, and the crowns had been placed on them, and so of course they're not going to be movable whenever we're going through clear aligner therapy. But what we were able to do was we could move around them, because the movement, as far as they were concerned, were not going to be significant enough to require us to have to redo the restorations. So whenever his treatment plan came back, Gene had 21 aligners, and Gene really wanted to make for sure that he got through this. He didn't know how well he was going to tolerate wearing the aligners to begin with, and so he wanted to make for sure that we got through this as quickly as possible. So on Gene, what we ended up doing was we did the micro-osseous perforation on the day that we delivered, and we reduced his delivery from 10.5 months to 4.5 months. So we started out at 7-day, and we got partially way through, and then we went to 5-day aligner change out when we had done a majority of the movement, and we could speed the movement up even further. The treatment was completed with 21 aligners, and again, there was not any refinement that was required on his case at all. So when we go from there, we go to Kimberly, and so this is where things get a little bit interesting as far as some things that we have decided that we were going to do in our practice. So whenever we began to do clear aligner therapy, we originally decided that what we would do was in our cost of our treatment that we would have an extra fee for doing Propel, but that in our fee we would include bleaching, and we would include the retainers. And so whenever we put that all together and we came up with what our fee was going to be, we then would then add, if you want to make this faster, then we will add Propel, and the Propel at that point in time was $500. And so what happened is over the next 3 cases I'm going to show you, and the problems that we ended up running into, we made a decision in our practice that a couple of things occurred. Whenever we talk about earlier about the pros and cons of it, what we found out is that if we use Propel, 2 things happen. We could move them through the aligners quicker, and all of our movements became more predictable. And the most important thing to us actually was not moving them through quicker, really, as much as our movements became more predictable and we had fewer refinements and extra aligners. So this is Kimberly. She walks into our office. She's actually working for a specialist in town at this point in time, and she's got some TMJ issues. She has TMJ issues enough that we put her in a full-time splint therapy to get her comfortable and to get her pops and clicks under control, and actually to get her headaches under control. She had ortho relapse, and if we look at the right side, at the left side on your screen, you're going to see that she really is pretty much a half-step class 2. Her interior is a slight class 2 div 2. She's got those centrals are tucked back in. If you look at her arch form, she's slightly omega-shaped arch, and she definitely has got a posterior collapse that's occurring. So all of these are causing her to have premature contacts, and they're just exaggerating any kind of TMJ issues that she was having. So honestly, whenever you look at this case, you go, man, this ought to be a slam dunk easy case. So we felt like that we had her comfortable, that we could put her into a clear aligner therapy. We could make for sure that her condyles were seated correctly, and we could move the teeth into the best position, and everything would be great. What we found out is Kimberly's a little bit of an impatient young lady. So her first treatment comes back, and she's got 13 aligners. She only had 2 teeth that actually had even moderate difficulty. And so we're at that point in time, we're doing 14-day change. And actually on this case, this is right before I started scanning for my, doing digital scans for our Invisalign cases. And so this was an impression case. So she gets about 7 aligners in, and she just completely loses interest. And next thing we know, she's not making her appointments, and we're not seeing her. What you'll find out from this case is, you know, I kind of hang on for dear life sometimes. Maybe I should, maybe I shouldn't, but in this case, this is what ended up happening. So she comes back in. She's basically pretty much looks almost exactly the same way as when she started. So we scan her this time, and it comes back, and there's 4 teeth on the lower that now have moderate movements that need to be done, and now then she's got 16 aligners. And so we are talking to her about the fact that we're scanned her, so maybe these should fit significantly better, and the movement will be more predictable. The problem wasn't the moving being more predictable. We got about 7 aligners in, and guess what? She ran out of steam again, and she disappeared. As a matter of fact, she ends up in somebody else's practice, and they say that they will not take off the attachments and send her back to have the attachments taken off. So whenever she comes back in, I'm more than willing to go ahead and just take the attachments off and let her go on her way. But one of my assistants talks to her about the fact that we can do Propel, and we can get you where you want to go, and we can cut your time in half. And that kind of perks her up. So she says, yeah, she's willing to do that. And so we scan her again, and this time it comes back with 14 aligners. And so we do Propel on her, and we go through a 5-day change because she's nice, she's young, she's 22. Those teeth move really pretty quickly, and whenever we do the micro-osseous perforation, 10 on the top and 10 on the lower, the results are 2 months. 2 months is all that it took for us to get through the 14 aligners, and her case was completed. And she did not lose steam on this case. She saw the movement occurring quickly. Whenever you're changing them out every 5 days, every 15 days you're going through 3 aligners. So that's 3 aligners every 2 weeks. So this case ended up turning out very successful at that point in time. Whenever this case occurred, then we began to start thinking, maybe we need to reevaluate exactly how we charge for our cases, and maybe we need to start considering including that in our fee. So then along comes Melanie. So Melanie is 38, and Melanie is a post-ortho relapse. She won't necessarily explain to us what she was doing, but she obviously had a noxious habit that holding something in between her teeth to make tooth number 7 and number 8 and number 6 move in the way that they moved. And also for her to almost have a complete crossbite over there on the top on the left-hand side. So whenever we talked to her, if you took a look, she had very sensitive teeth. If you were able to look up close, you're going to see a lot of abfractions. She has a pretty significant, and you know what? I've got the upper occlusal images are reversed because that should be on the right side instead of on the left side, I think. Anyway, so she's got an omega-shaped arch, and it's pretty collapsed over on the right side. And if you look at the lower, you can see that the lower are pretty well collapsed. So what ends up happening with Melanie is we start out with Melanie, and her case comes back with 15 aligners. And we talk about doing Propel, and we're talking about doing Propel so that maybe she can get through it faster. And the $500 charge basically pushes her back and scares her back in a way, and she feels like she'll be fine just doing the other. So whenever we go through with the 15 aligners, it's a normal 7.5-month treatment. And then whenever we get to the end, we found out that some of the teeth that we needed to move, they didn't move quite all the way where we needed for them to do. And we really wanted to go back through and do a little bit more, have a few additional aligners to finally finish out her case. At that point in time, she began to get a little bit interested in maybe considering doing the Propel. So when push comes to shove, we're going to have 10 more aligners. We get about 2 aligners into it before she goes, wait, I want to get this thing over with. So we're about 2 aligners into the refinement, and we do the micro-osseous perforations, and then she goes to a 5-day change-out. And because of her, we really begin to start looking at the fact that, okay, number one, patient compliance is being greatly affected by using micro-osseous perforation, and number two, not only is patient compliance being affected, but guess what else? Some of our tooth movements are becoming much more effective, because whenever we look at the final product that we have on Melanie, it's hard to believe that we actually could get all of that done. There was some question as to whether we could make these moves occur on the left side, and they did occur. So then the one that kind of seals it for us is Paul. So Paul's 50 years old. He's class 1. He's got a reverse swallow issue. He's got edge to edge in the interior with spaces. And the first thing you're thinking is, you're going to do Invisalign with this case. So here's what my history has been with doing Invisalign whenever you have a tongue thrusting problem. As long as they're wearing their retainers whenever we're through, at the end, the teeth don't move. And that's been our success so far, and that has ended up being the case with Paul. So Paul is about 2 years post-op. He is still wearing his aligners, and you can see that they have not moved at all. And so what we ended up, whenever we did his case, his was going to be 28 aligners, which meant that that would be 14 months. So his first 14 aligners were a 10-day change-out. So we felt like that we could, majority of the movement was just pulling the anterior teeth back in and closing the spaces down. And we talked to him about doing Propel, but he really wasn't that interested in spending the extra $500 at that point in time. So we get about halfway through. It was aligner 14. He decides he wants to get finished quicker. So we've been moving pretty good with 10 aligners. And as we were moving through with 10-day changeout, and he decided he wanted them to be quicker, we decided that we would check and see how well he would do if we actually cut it in half and did a 5-day changeout. And the reality of it is this teeth moved wonderfully whenever we did the Propel. And so we went to a 5-day changeout. So basically we go from a 14-month to 4 months plus 2.5 months. So a total of 6.5 months as opposed to 14 months. And this was his end result, which turned out pretty spectacular. So whenever we started looking at that, the thing that we found out was it was very easy for us to start talking to our patients about the things that it does for us. So currently in our practice now, the way that we structure our fees now is we'll have a case fee and we base it on predominantly on crowding. Because what we've ended up seeing is related to crowding is also related to how difficult most of the movements. I'm not going to say it's 100% that way, but I'm going to tell you it's probably 90% that way. So if we have less than 3 millimeters of crowding, then we're going to do an express form of a case of 10 to 14 aligners. We're going to then have a fee that's going to be considered our normal orthodontic fee if we are doing up to 6 millimeters of crowding. Then if it's more than 6 millimeters of crowding, we call that a complex case, and we have a fee that's slightly higher for that case. All of our fees now include retainers. They include bleaching that goes along with it, and we also include any acceleration. That way we make for sure that if we feel like we need to have acceleration in the case, and I will tell you that probably 80% of our cases now have some form of acceleration associated with it, whether it is the V-Pro 5 or whether it is actually the micro-osseous perforation. It's all included, and then we're not having to go back and say, oh, by the way, if we want to get this, then we need to do this, and it's going to be an additional fee. So we have just packaged that all into the price of our orthodontic services, and it's making things much more successful in our practice and predictable, and our patients are being much happier with what's going on. So the last two cases I'm going to show you are using high-frequency vibration. And actually, the last two cases, one of them is a high-frequency vibration case, and this one is my poster child for high-frequency vibration cases. And then the other one is going to be a combination case. So the next case is John, and John's a 20-year-old young man, and John's he's kind of half-step class 2 also. He's got a class 2 Div 2 on his maxillary anteriors, but he's got spacing on his mandibular anteriors. So he's had some issues since he was about 16 years old with clenching and grinding and having morning headaches, and so he's been in a nighttime splint for that to help treat that. So whenever we start talking to him about trying to better position the teeth for that, our consideration is going to be we can kill 2 birds with 1 stone. We can use Invisalign to help us position the teeth correctly, and at the same time it's going to act as splint therapy for us. So John's parents were all in on this. John's still in college, and so we put this forward, and this case is going to be 30 aligners. Is what it's going to take to make all of the movements and make them predictable. So that's a 15-month case. So what we decided was this case was going to be, since he was this young, we were going to use the V-Pro 5 only, and we would have a 7-day aligner change. And so what's happened is actually we just finished his case, and so we finished that with 6 months. In 6 months' time using a V-Pro 5, 7-day change until we hit aligner 13. Then once we hit aligner 13, we had a majority of our movements done, and we chose then to move down to a 5-day change until the end using the V-Pro 5 once a day for 5 minutes. The treatment has been completed. We're right at the point of making his retainers really right now. and there's been no refinement. So we've got minor equilibration. His TMJ symptoms completely resolved within 4 aligners, and so we would consider this to be a very successful case. And on this age, it's been really great to see that the help of seating the aligners by using the vPro 5 was more than enough to help us make the movements be successful and shorten our time. So the last case that I have is Jerry. So it's taken me a while to talk Jerry into doing what we really needed to do for Jerry. So Jerry is clasp 1. He's got an omega-shaped arch form. If we take a look, his case is going to be difficult because he has hyper-erupted lower incisors, and personally, in my hands, those seem to be some of the most difficult movements, is just pretty much a straight-on intrusion of those lower anterior teeth. If you take a look at him, he also has got some pretty traumatic occlusion. If you'll notice, he's got a 9x11 bridge. Tooth number 10 is missing, and if you'll see where tooth number 10 on the bridge is striking tooth number 22, his lower cuspid, you're going to find out that's the reason he lost tooth number 10. He took a pop, and it damaged the tooth, and the tooth never could appropriately respond. Also through his time, even though he's only 37 years old, he's developed a early reciprocating click in both joints. He's had nighttime headache, morning headaches, and we have had him in a splint. And so we talked to him about correcting the position of the teeth, aligning them so the forces are better, allowing us to get his joints positioned in the right position, and that we felt like that we could take him out of having to use a nighttime splint anymore and help him to become headache-free. So in his original treatment plan, if we take a look, you can see the omega-shaped arch on the upper and how collapsed it is on this side. You can see how collapsed the posterior teeth are and how they are leaning in. So the original plan is it came in with 24 aligners, which is going to be a 12-month treatment, and we were going to use micro-osseous perforation for a couple of reasons. Our main reason was I felt like that we were going to have difficulty getting these lower anterior teeth to complete how we needed for them to be, and lo and behold, that was going to be the truth of that. So we started doing his, and he was feeling really comfortable and felt like that most of the trays were getting loose within about 3 days. So we went through a 5-day change on him and did micro-osseous perforation. 4 months later, this is where we ended up on the right side. So we didn't get fully completed movement. And you know what, and I'll be honest with you, maybe we would have gotten more of the movement expressed if we had been a little more patient and done 7-day change out. But regardless of that, we did a refinement on him, did additional aligners. It came back at 14 aligners, and so we made the decision this time on the 14 aligners that we would slow the movement down a little bit, and we'd use the vPro 5 and see what our results would end up being. So here's the finished case. And this is one of the reasons I wanted to show this case last, because I think the case turned out fantastic. So we used the vPro 5 for the 14 aligners. We changed them out on a weekly basis. It was just an additional 3 months that he had to do, and it takes us and it lets us, we go from here at the beginning of his case. Here's our mid-course treatment on this case, and there's the finish on the case. So it was 3 additional months. So we used 4 months on the front end, 3 months, so that's 7 months. So we cut his treatment time to 7 months, and we still even had a refinement to get us there, and it still brought us in 5 months less than what the original plan of 24 aligners was. And so this is what we've kind of learned out of all of this, is that whenever we are very careful about how we set this all up, that we can use a combination of both using micro-osseous perforation and then follow that up with vPro 5, and we can be very successful in making these cases work out really, really well. And so this is what we've learned out of this place, is it makes it very easy for us to go back and talk to our patients about the fact that if we are using this, we can keep them very comfortable. We wake the bone up so that we can get that bone to move at a much easier rate and much more predictable rate, and they'll actually see their treatment time typically cut in half. And so that is what we've ended up seeing, and that's what we feel like, what I feel like that you can easily incorporate into your practice successfully. So with that, I want to thank you, and now we're going to go ahead and I want to open up for any questions that we may have. So we've got about 10 minutes worth of time, so for any questions that you all may have out there. Okay, so what is the protocol for patients with tori buccally and or lingually with Propel, and how does tori affect the tooth movement? Well, you know what, that is a really, really good question. And honestly, what we end up doing whenever that happens is we will warn the patient that we may have even a little bit more difficulty getting that tooth to make the movement that we need to do, but we will do probably a couple. In that case, we would move to the lingual if we could, if they have the buccal tori, but honestly, I can tell you I haven't run across a case where we've had to do that with buccal tori. So that's the first thing that I would tell you, is I haven't had a buccal tori case. I've had cases where they've had lingual tori and the teeth have moved excellent. That hasn't changed the movement on them at all. Any other questions? What are the diameter or the mop holes that are made? You know what, the diameter is less than it's about 1.5 millimeter diameter hole. And so that's really what actually is it's the size of a very, very small, it actually even looks like a stainless steel screw. So what techniques do you recommend for extruding maxillary lateral incisors? Well, Jessica, that's a really good question. Here's part of the thing that ends up happening with the extrusion of maxillary lateral incisors, is that seems to be one of the most difficult movements that's out there. And the first thing that I would end up telling you would be, whenever you feel like that the lateral incisors are not moving, is I would go back and I would take a look at the movements that are being predicted. Is it actually the laterals that are supposed to be being extruded, or is it actually the centrals that are supposed to be intruded and the laterals are not being extruded? And I think what you'll find is probably about 70% of the time when the laterals aren't moving, it's because the centrals are the ones that are actually holding up the spot. And so in that case, that's where it becomes really critical. If I see that I'm going to be intruding my central incisors and I'm going to be intruding them more than 1.5 millimeters, then that's the sites where I'm going to make for sure I've got 2 or 3 micro-osseous perforations per site to try and wake that bone up enough that I can see that movement be expressed. If I've got a movement like that, I'm going to be very careful as to whether I'm actually going to allow them a 7-day change-out. If that movement is not being expressed, then I am probably going to slow that movement down, and they may be on a 10-day movement, and I've even had a couple of cases where we've used the mops with it and they've stayed on a 14-day movement, but that's a very good question. What factors do you consider when deciding the frequency of a liner change? You know, there's a significant number of ones that you really have to consider, and that's going to be part of, so I have the luxury of using Invisalign, so I have to relate it back to what I'm using. So whenever I'm using Invisalign, I'm going to look at the tooth movement assessment chart first off the bat, and I'm going to see what they are deeming to be a moderate, which would be a blue movement, or a black movement, which would be a difficult movement. And those I'm going to make for sure that I'm doing the micro-osseous perforations, maybe an extra perforation around each one of those movements, as well as the other movements that are going to occur. The other movements that I'm going to actually be really looking at is going to be intrusion and extrusion of the anterior teeth. Especially the intrusion of anterior teeth are really pretty difficult to do, and so those are the cases, and you're going to find out that you've got really quite a few cases that have got, or I do anyway, I see quite a few of deep bite cases that require some amount of intrusion that really need to ensure that I'm using some form of acceleration device to try and get that to work. That's a really good question. Janine, I have a 70-year-old female who is concerned about MOP due to osteopenia. What's your verbiage for patients who are hesitant due to bone density issues? You know what? The way that we typically end up handling those patients are going to be that we just, in the past, we have not had any problems with any kind of movement issues because of osteopenia. Now then, if they've got true full-blown osteoporosis, that might be another issue, but as long as they're staying away from NSAIDs, then they shouldn't have to worry about the problem of the teeth being moved. The teeth are going to move quite easily, and the healing is not going to put them at risk. So if you have a high-frequency accelerator is used twice a day, is there any additional movements versus once per day? I don't think so, Terry. I think you're just giving them extra time on the device to help making for sure that they're getting them seated. So I think there's nothing wrong with doing that. Okay, so with that pretty well takes care of all the questions, and I want to tell you, everybody, thank you for coming on tonight, and really appreciate you being here this evening, and hope you all have a great rest of your week.